Today, I'm going to be speaking with Dr. Anupam Jena, who's a physician, economist, professor at Harvard, co-author of Random Acts of Medicine, and also host of one of the few podcasts I actually listen to when I'm, on the treadmill, on the elliptical, Freakonomics MD. Really great having you on. I appreciate it.
Thank you for having me.
So maybe to start with, so many of your episodes will take a specific question, a medical question or an aspect of medicine, and do sort of a deep dive into it. To make the first kind of topic general, are we getting better at getting definitive answers when it comes to a lot of these questions in the following sense? It seems as though even when we talk about randomized controlled trials, long-term studies, longitudinal studies of trials that have been done, there's always this feeling that, okay, is the result we're getting influenced by randomness, a factor we're not considering? When it comes to diet questions, is it the addition of something or the elimination of something else that we're maybe not correctly tracking? You hear this about eggs or coffee or whatever the case may be. You had a great episode on colonoscopy. What are we getting better in your mind at really getting answers we can be very confident about with a lot of these what's best for human health, or are we not really there yet in your mind?
So I'd say we're not really there yet. And I think we're getting better in a lot of respects, and we're getting worse in some other respects, or at least staying status quo. So the places where we're getting better is where we actually have high quality evidence. So you use the words randomized controlled trial. It's when you take a bunch of people who have a medical condition and you randomize half of them to get a treatment and half to get another treatment or maybe nothing at all. And that allows you to say with some certainty whether or not this treatment works. Does it have a cause and effect relationship with the outcome we care about? So those types of data are very good. We try to make most of our decisions based on that kind of information. But what you hear about in the news, what we read about in medical journals is often not that kind of information. Rather, it's what we call observational data. It's relationships that we're just observing based on who is using a treatment, who is drinking coffee, who is drinking red wine, and people who aren't. And those kinds of data, I think, are very much at risk of leading us down the wrong path. And probably the best example of that kind of work is in nutrition. So what are the effects of moderate amounts of red wine,
Right.
moderate amounts of alcohol, dietary things? That kind of literature is, I think, very suspicious in my own view.
There are movements that are taking over social media platforms at this point when it comes to nutrition and the connection to health and longevity. There's been, the carnivore diet people. There's the seed oils are inflammatory and you should never have canola oil. And if you have only olive oil, first press, ideally, you're going to live 10 years longer. And then there's usually some blowback where it's, hey, it's based on like a petri dish study. It seems that in humans, canola oil may actually be anti-inflammatory. And then there's like a counter to that. What's your advice in terms of minimizing the noise and increasing the signal when it comes to all of these fads and trends that we start to see?
I don't personally put a lot of weight on those kinds of studies. I think basic things like eating a somewhat healthy diet, fruits, vegetables, proteins, some carbs, and a healthy amount of exercise and activity. Those things I think are very reasonable, and there's good general evidence for those sorts of things. It's really in the fringes, but I won't even call them fringes because it's like dominates what we hear about, where I think the evidence is really not very strong. And so long as you're trying to do those two things, right, like generally eat healthy, generally be active, that's where I think we have good evidence. Everywhere else, it's really not something I put a lot of weight on.
There seem to be sort of two movements that have a bit of attention right now when it comes to health and longevity. On the one hand, there's the movement that's about adding stuff. It's what about starting to take NAD? What about taking metformin? What about overloading on blueberries because of their supposed effect, right? So it's the add. You need to find things to add. Another movement is about we actually want to not necessarily take away, but maybe simplify, right? Let's just keep out certain things, keep out ultra processed foods, avoid a sedentary lifestyle, etc. I'm not asking as if you have a definitive answer and it's hard to predict these things, but from what you follow, do you believe that the path to a predictably better health span, as we might call it, is going to come from finding stuff to add or simply from avoiding things that are damaging?
Well, first, let me say I got a couple of supplements I'd like to share. No, I'm just joking. Uh, I think it's probably a little bit of both. And you had a really interesting insight just a moment ago. When you add something, you're sometimes subtracting it as well. So you can't separate whether it was the addition of something
Mm,
versus the subtraction of something that generated the effect that we think it did. Um, I think probably subtracting some things is not a bad idea, but the types of things I would propose to subtract aren't sort of the sexy things. I'd say, you want to subtract high fat, high calorie foods. That's a natural thing to subtract. Not completely, but to some extent. Adding things like exercise probably matters. There's a lot of studies that look at the relationship between walking and exercise and outcomes, and there certainly is some causal effect of exercise, but it's probably not to the level that we see in some studies because people who have time and the ability and the interest to exercise are doing a lot of things differently for their health,
right.
and you can't figure out whether it's the exercise versus everything else that they're doing. So I'd say there's probably a little bit of both going on, adding and subtracting.
I want to talk a little bit about the role of, I don't know if we would call it chance or odds or sort of coincidence in this entire conversation. I think everybody has heard stories of exercised every day, ran a 5K once a month, ate a perfect diet, whatever perfect is in the mind of whoever's kind of analyzing this, and yet something happened to them, rare disease or early death or whatever the case may be. What is in your mind, especially since you're both a doctor, but also an economist who might answer some of these questions at a population level, what should be the role of chance and randomness in thinking about a lot of what we do as individuals with regard to health and also with regard to health policy?
Good question. I think there's two answers. First of all, is that none of the things that we think help us are necessarily cures. So even something like a vaccine which for, a good vaccine which we think might help prevent disease, it might not completely prevent disease, but it will reduce the likelihood that we die from it or that we get hospitalized from it. But it doesn't completely prevent us from the exposure and some consequences of it. And the same thing is true, like you just said, of immense amounts of exercise and a really healthy diet. It will improve your probability of living a longer, healthier life, but it doesn't guarantee that for all the sort of reasons that you described. Some would be totally random, like getting hit by a car, um, maybe a genetic predisposition to something. Those things are kind of out of our control, but they do help. The second thing is, in the book, Random Acts of Medicine, we talk a lot about how chance affects our lives, but it also teaches us something. So, for example, we've been talking about diet. There was a really interesting study that I talked about on the podcast as well, where these researchers looked at this policy towards sugar intake in the United Kingdom around World War II, I think it was. And basically, there was a rationing of sugar for some period of time for war purposes. And what they found was that these cohorts of people who were born around that period of rationing, they got exposed to less sugar early in their life. Two, they were less likely to use large amounts of sugar later in their life, in part
Mm,
because they hadn't probably built that interest in sugar from an early age. And
right.
then three, they had less problems with things like diabetes and other inflammatory medical problems later in life. So that's a nice way that chance allows us to understand something about what works and doesn't work in our healthcare.
By the way, when we look at something like that, do you feel that that sort of study actually accounts for all of the factors that would influence such a determination? Or is even a study like that missing some of the things that might be crucial to know to be able to say, hey, here's what's actually better to do?
Great question. So I think that kind of study is better than one where we just look at people who eat a lot of sugar and people who don't, because those people are different in so many ways
Right.
that you can't possibly control for all of the things that you might be able to observe and all the things that you can observe. What I like about the kind of study that I just described, which is we call that a natural experiment, is that you can directly look and see whether the cohorts of individuals who are just by when they happen to be born, exposed to the rationing of sugar, and those who, again, by chance, when they happen to be born, were not exposed. And you
Right.
can see, are they similar in all other characteristics? If they are, then the only difference between them is that one group was exposed to limited amounts of sugar and the other one wasn't. The other group wasn't. Again, arguably by chance. But even those kinds of studies aren't perfect because you might pick up other differences between the groups, in which case you would be worried about saying something about cause and effect.
Thinking now with your medical knowledge, but as an economist, what are the sorts of large sort of interventions or campaigns that are most effective? And when we think about things like, well, we could ban sodas of a certain size, right? Or we could have money into an anti-smoking awareness campaign. Or what about making vaccines free at the point of injection rather than whatever, right? Include any sort of population level intervention that could be done. What sorts of things do we know have the biggest impact?
That's a great question. So I would say the following. I think the things that have the biggest impact are the things that make it easier for us to do what we want to do. And I'll give you two examples of that. So the first is we've been talking about diet and exercise and health. There are these new medications that many of your listeners have probably heard about that are being used for diabetes, but also for weight loss.
Right.
Now, it turns out losing weight is really, really hard to do. So if there's a medical technology that allows you to do something that is otherwise really hard to do, that's very valuable. And there's obviously a lot of interest in people to use that. What are the long-term effects and outcomes? That's harder to know. But that sort of technology, I think, is very valuable because it reduces the barriers to achieving what we want to achieve. The second example would be related to costs. So we spend a lot of time in health policy thinking about what are the costs of care. Insurance reduces the cost of care. Making drugs free, making vaccines free, reduce the cost of care. But what we know from a lot of studies is that even when you make something free for somebody, they're still not that likely to use it. So there's a famous study about heart attack patients, which showed that even when heart attack patients were given medications for free, 50% of the time they weren't taking the medications that they're supposed to take after a heart attack. So that tells you it's not the cost of the drug that's the barrier. Maybe it's the feeling that I have a medical condition and there's a stigma that you internalize there. Maybe it's the cost or the time cost of going to the pharmacy to fill the prescription, the mental energy required to remember to take the prescription. So anything that reduces those barriers, I think, is much more substantively impactful to improve health than focusing on the dollar cost of whatever intervention we're talking about.
Yeah, if we continue thinking a little bit about healthcare through an economic lens, there's sort of a unique reality about healthcare services when it comes to demand, which is extreme inelasticity in a sense. And the discussion I've had with my audience before is, before I started having appendicitis, I was completely insensitive to the cost of an appendectomy with regard to my interest in it, right? Whether it was 30 grand, $1,000 or even free, I didn't need one, so I had absolutely no interest in it whatsoever. At the point at which I started experiencing pain and ended up at the hospital and I was told, you're having appendicitis, at that point, I was also in a position that is very unlike most markets and supply and demand, which was now, I don't even care what the cost is. I need an appendectomy and I need it very, very soon. This seems unique to medicine and to healthcare, and thus it seems logical that we would evaluate the healthcare industry and market and health insurance differently. There are those who want to say it's just supply and demand and we should basically open the door and think about it like cell phones or airline tickets. And there are others, including people like me, who say, no, our policy needs to be different because of this difference in fundamentally how it works. Can you talk a little bit about that and what sorts of considerations are important when you have this sort of inelastic demand situation?
Yeah, I think both groups are right, and you focused on a very natural situation, which is where there really is no option but to treat it. So if someone has a life-threatening heart attack, they're going to want to get care at really any price, right?
Right.
But it is the case that if you have chest pain, you're at home, you have chest pain, your likelihood of going to the emergency department might depend on how
Right.
generous your insurance coverage is. So you may not even go, or you may delay going until the point that your chest pain is so severe that you're like, I have no other option.
Yeah.
So I think you're both right. So at the point where you're in dire straits, you're in need of a medical intervention, people will tend to be less sensitive about the cost. But at other points, they might be more sensitive. And we see this, for example, for chronic disease medications. For some chronic disease medications, people tend to be more elastic. In other medications, like cancer medications, they may tend to be less elastic with respect to price because in that moment they prioritize so much getting treatment.
And so, from a public health perspective and a what should health insurance companies be required to do sort of perspective, what's the approach? I mean, I know that this is a big question and a complex issue, but what sort of principles should be applied when we think about that?
Great question. So I think, it really depends on a few things. One is what are the interventions that we think work, how much they cost, and what are the barriers to people to using them. So there
Mm,
is a movement in health insurance to try to make certain medications free to individuals. And the reason why is because they think that A, the medications are valuable to the person, it'll improve their health. But it might also be the case that if you make it free to someone, they'll take it, and that might lower the other costs of care. So, for example, you're less likely to be hospitalized if your chronic disease is better managed. So that there is a movement towards making a lot of things free. And if you do think about it, right, it's not like a bag of Doritos or a car, right? Nobody, anybody who's taking a medication, they're taking it because they feel like they need to take it, not because they
yes.
derive some utility from taking it. So your points there, I would totally agree with. The other thing that's a little bit different about insurance is that there is this recognition now that one reason why insurance companies might charge co-payments out of pocket costs to people is because they might want to use that as a form of selection. A health insurance company wants to, from a financial perspective, try to attract healthier enrollees because
Right.
they cost that insurance company less. One way to do that is to say, all right, well, if you have this medical condition that's costly, we're going to charge higher out of pocket costs for that. And by doing that, they would dissuade those types of enrollees who may have higher costs from choosing that insurance plan. Now, from a societal perspective, that's not what we would want, but you
Right.
could see how that kind of thing might unfold.
100%. And I guess that would be the argument to say the profit motive should be removed altogether, which is a whole other conversation in terms of approach. And we would have to, it's a different conversation, but that would be an argument to say when it comes to cell phones, that's fine. When it comes to health, some would say we should be removing that motivation altogether.
Yeah, yeah. I mean, I think that, people will differ on that because it is the case. I think that sort of the search for profits may improve quality, and there's a lot of thinking around that overall in economics and also in medicine. But
Yeah.
I think the bigger thing I would think about is like, what is it that's going to improve patient care, right?
Hmm.
And I think it is the case that for at the point of care, making things affordable, maybe even costless to patients, you might even consider contemplating paying people to take medications because of the other barriers that we talked about. Like it's just, you don't want to take a medication because you don't feel like taking it, or it's
Right.
hard to get to the pharmacy, whatever it may be. Those sorts of things I think are worth considering as well.
We've been speaking with Dr. Anupam Jena, who is the co-author of Random Acts of Medicine and also host of the Freakonomics MD podcast. Really appreciate your time and insights today.
Thank you for having me.